Morning, ladies and gentlemen. My name is Dr. Asim Jamal. I'm a medical oncologist at the Aga Khan University Hospital here in Nairobi. I thank the EOTIC on behalf of my co-authors as well to accept our research for oral presentation. I'll be talking about determinants of pathological response to neoadjuvant chemotherapy in Kenyan women. Breast cancer is number one cancer in Kenya, as is for the rest of the world for women. Neoadjuvant chemotherapy facilitates surgery and prognosticates outcomes. This study investigated factors that could be linked to the response to the neoadjuvant chemotherapy. We analyzed records of 67 patients with demographics and treatment received and the tumor characteristics, and we assessed the pathological response evaluated by residual cancer burden index, which is a validated and accepted modality of response assessment. We looked at the impact of pathological response in long-term survival and event-free survival for these patients. The demographics of these patients were as this, and the treatment received for our patients was most common chemotherapy was AC4T followed by FACT, and most of our patients received MRM as a surgical procedure. In results, we had a PCR of about 12.3% and 8.8% patients in addition showed RCB class 1 response, which is a very good response. But most of our patients fell into grade 2 and grade 3 RCB or class 2, class C RCB, where the response is either not so good or the response is quite poor. On the right side, you can see the exact divisions of the patients who fell into different RCB classes. Remember, the lower being the higher response, and as you go up, the response becomes poorer, and the dotted lines represent the difference between the RCB classes. In overall, 21% of our patients fell into a good or an overall better response in terms of RCB 0 and 1. From the factors, we looked at different demographic factors and clinical factors. None of the factors reached statistical significance in terms of response to neoadjuvant chemotherapy. However, we looked at the tumor grade, and the tumor grade was actually a higher tumor grade was associated with a higher response to neoadjuvant chemotherapy. IHC subtypes, hormone positivity or negativity in our study at least did not show any difference in terms of survival. This histogram shows the tumor grade association with a higher response. As you can see, the higher the tumor grade, the lower the RCB class, which translates into a good response. I also wanted to highlight this wide variance in the TNBC population, which might speak of heterogeneity within the TNBC group of a possible inherent differences as the response spread was quite big in the TNBC population. RCB turned out to be a very good prognostic indicator of long-term survival and event-free survival in terms of distant metastasis and local recurrence. Again, going back to the treatment, significant patients actually also showed having received BCT. In conclusion, what we can say is the standard neoadjuvant chemotherapy in Kenyan women with breast cancer achieved a good response in about 21% of the patient. There was trend towards increased pathological response with a higher tumor grade. Breast conserving surgery was noted in our study to be higher than other African studies. Improved outcomes were seen with the lower RCB, which is a good response, and IHC subtype in our study did not differ in terms of response achieved. However, the TNBC, as I said before, responders were varied widely within the group in terms of response, which is an area that we might want to look for further studies in future as well. I thank again the EOTIC for accepting our abstract for oral presentation, and these are my co-investigators on the screen. Thank you.